All right, thank you, Dr. Sean, for this introduction. I'm happy to be here with you all. Everything we do is for the patient and about the patient, so uh, there's nothing that I do special. It's just all teamwork. Everybody would work together in order to help the patients. Whatever the patient needs, we'll adjust and we'll change our management based on what each patient needs. So I'm an intervention radiologist, so what I do is I treat cancer using pinholes in patient rather than cutting the patients open. In order, when a surgeon cuts the patient open so he can see or she can see what they're doing, because we don't cut patient open, I need to use something to help me see inside the patient. So we use, as Dr. Shahan said, ultrasound, CT, or MRI, or something that's going to help me see inside the patient. My involvement with treatment of NET patient is when patients have liver metastases, when the tumor goes into the liver. This is where I'm involved. So I rarely see patients come to me first. They would come to Dr. Shohan and our NET team, and then they will assess if there is something that I can help them with. So this is where my role comes into play. So. You can't hear me? How about now? All right. You want me to start over or no? But I talk a lot, so I was trying to keep myself from. All right. So for treatment of neuroendocrine cancer that has metastasized or went into the liver, patient can undergo surgery, patient can have radiation therapy, or systemic therapy, or liver-directed therapy, or local regional therapy, and this is my role. Who can benefit from local regional therapy? So any patient that has NET cancer can come and be a candidate for local regional therapy or not. So let's see who are the patients that will benefit from this. Patient will be candidates for local regional therapy are the patients that have cancer in their liver that is unresectable. If there's something in the liver, if somebody can cut it open and take it out, probably go this route. There might be other reasons that patient, either they are not candidates for this or they do not want. It's like, I'm not going to have surgery. So patients will fall into this category where they will be candidate for local regional therapy. Well, I think I went backward. So patients who have progressive disease. If patients have metastasis in their liver and they are on systemic therapy or some sort of therapy, and still when they come in for their follow-up, they see that there's still disease progression, then they will be candidate for my type of treatment. Or patients who have symptomatic disease, so they have symptoms, they are on treatment, and they still have the symptoms, diarrhea, abdominal pain, or any other symptoms that they may have, then also we can be part of their treatment. And patients who have bulky disease, so if a patient comes in to the medical oncologist after they have been diagnosed with neuroendocrine tumor and there are tumors all over their liver, probably you don't want to wait on chemotherapy or other treatment modalities that will take longer to work. Those patients may come in and then we can address them quickly. So what is local regional therapy? So there are different types of local regional therapy for neuroendocrine tumor liver metastases. This is the one that we least use. It's ablation, where we use tiny needles. We put them in the liver, and then we burn or freeze the tumor in the liver. So instead of having this cut off, just a needle, burn or freeze the tumor. Most of the times, because neuroendocrine tumor, whenever patients show up to the doctor, they've already have so many tumors in the liver, or the size of the tumor is so big that this type of treatment may not be enough. And then this is the treatment that they will be candidates for. What we call embolotherapy. And this could be blend embolization, chemoembolization, or radioembolization. So I'm going to talk about each modality. So those treatments are where we're going to go in with a catheter that is the size of a cooked spaghetti in the groin, just like a cardiac cath, in the groin, and then I'm going to find my way inside the vessels to get all the way to the liver. Once I'm in the liver, then this is where I'm going to try to do something. What I'm going to try to do is either cut the blood supply to the tumors only and then let the tumors suffocate, or we can put some chemotherapy on those beads that I'm going to deliver that will help me, in addition to cutting the blood supply, have that chemotherapy work in the liver. This chemotherapy is not in the vein circulating in the body. So the rest of the body will not see that chemotherapy, only the liver. So there's no main side effects, just like taking any regular chemotherapy, because it's only going into the liver. Or radioembolization, this is when instead of putting the chemotherapeutic agents on the beads, we put some agent that would radiate, so called some radiation, and let that work inside the liver. We do our procedures in our intervention radiology suites. I need something to help me see, so I'm going to have to use X-ray. And I'll be like looking at the screen, just like video games, you know. I am far from the patients. I'm manipulating things, and I'm looking at the screen and seeing what I'm doing. And this is either that donut is the CT scanner, if I need to use a CT scan, or those machines like arms that move around. This is X-ray, so I can see where I'm going. So I said that I'm going to go into the tumor, into the liver, and cut the blood supply to the tumor. So by cutting the blood supply to the tumor, I am cutting the blood supply to the tumor and surrounding areas and the liver. And you will be like, oh yeah, great idea, doc. So you're going to cut the blood supply to the tumors and you're going to kill my liver. Thank you so much. Where the liver, only the liver has this advantage in terms of the liver gets 2/3 of its blood supply from the portal vein. And as you can tell, it's bigger than the red, the artery. So the liver gets its blood supply from the portal vein, 2/3 of its blood supply, while it gets the remaining 1/3 of its blood supply from the hepatic artery. So the liver, 2/3 from the portal vein, 1/3 from the hepatic artery. The tumors will get their blood supply only from the hepatic artery. So I'll be like, okay, so tumor only from hepatic artery, liver 1/3 from hepatic artery. So if I cut the blood supply to the tumor completely, I kill it, I suffocate the tumor, the normal liver is not going to be affected. It's only 1/3. And even that 1/3 is like, I don't care about this. You know, 2/3 is from that big portal vein. So that's why I have a job. That's why we can do what we can do. The kidney does not have this option. The brain does not have this option. Any other organ in the body does not have this option. You cut the blood supply, they will die. The organ will die. The liver is fine. It's like, don't worry, man. Just cut the blood supply. Don't worry. So that's why we're able to do that. And what we do, so this is a tumor that's supplied only from that hepatic artery, from that artery that supplies the liver. And then what we're doing is just putting all those beads that are going to cause that tumor to suffocate and die. And those beads can be just those material that's going to block it, or we can put some chemo on them, or we can put some material that would cause some radiation on them too. So it's one of the three modalities. For example, this is a catheter. So I would go with the catheter from the groin all the way into the liver, deep into the liver, and deliver those beads. And this is what we call chemoembolization, delivery of cancer-killing medication through a catheter directly into the organ. And on the other side is that radioembolization, which is the same idea, same catheter. We're just putting some radiation on the beads rather than chemotherapy. And I'm going to show you some examples. So This is a patient that was referred to me. We discussed the patient in at the UK neuroendocrine multidisciplinary team, and on the top left is a CT scan of the patient, and this is the liver on the top, and you can see that there are those black dots in the liver. You can tell that there is something going on. When we got a PET scan, it demonstrated those tumors had uptake. So they took that material that we gave for the PET scan, and then they light up. So if you look here, you can see that it's all like lighting up. There's barely any more normal liver that is there. And in the middle, there's that projection as if the patient is standing in front of us. And then you can see this is here the bladder. This is actually the primary tumor in the terminal ileum in the intestine, and this is the liver with those tumor. And this is again the same one as the top left, but as if the patient is standing in front of us. They're just standing facing us. So this is the pelvis, this is the liver, the thing at the top is the heart, and the intestine in the middle. So this patient was referred to me for treatment. The reason, bulky disease, lots of disease in the liver. So what we do here at UK, we start the patient on everolimus, and then before we get some images, before I do my procedure, which is called embolization, we stop that drug for a day. Patient will undergo that treatment, and then we'll get a CT in a month or so. We give the liver time to recover. Even though we know that it's 2/3 from the portal vein and 1/3 from the hepatic artery, but still, I mean, the liver, just give it some time to recover. So patient can theoretically undergo the second, another embolization in 4 weeks, but we give them 4, 6 weeks, 8 weeks. Again, if you're going to go to a battle, I'd rather have you guys ready to the max, like you're ready to fight. So then we'll do another lobe. Mainly, with the reason we do this is that although the liver has 2/3 from the portal vein, 1/3 from the hepatic artery, still we're not going to go and cut the blood supply to the liver completely. What we do is we try in our mind to cut the liver in 2 halves, the right and the left, and we'll do one part at a time. Most of the times we do the right lobe first, because the right lobe is twice the size of the left lobe. So if I'm going to go for the money, if the patients can take one shot at it, I'm just going to go on the right side. However, sometimes the left lobe will have lots of tumor where I have to address the left lobe first. And that's what we did on that particular patient, because the largest lesion was on the left side. So this is a picture from my procedure. This is the catheter that's coming from the groin all the way into the liver. This is the spleen there. And this is the hepatic artery. This is the liver on that side. And I did the embolization on the left lobe of the liver on that patient. This is a month after the procedure. If you remember, when we looked here, everything was lighting up. And actually, I'm going to go back. So you see that big thing here? This whole thing lighting up? So this is after the first procedure. It just went cold. And that big tumor, it's just tiny. So that's the response on the left lobe. We let the patient recover. Actually, this patient, we gave the patient a year. We saw that, I mean, that's a beautiful response. You know what? We waited a year till we did the other lobe. I came back, same area. I have a roadmap. I know where I need to go. So I went there and did the right lobe this time. And this is after the second one. So not only the second one also respond, but that left lobe, which was done a year before, is still cold. It's still like that patient did not grow tumors there. So this patient came in 2016 when she was diagnosed, and then She was referred to us in 2017, early 2017. I did the left lobe in 2017, the right lobe in 2018. This is the image in 2018. Afterwards, patient underwent surgery for resection of the primary. That tiny ball that we saw in the on the first images, now patient had the primary resected. So we treated the liver, the metastasis in the liver before we treated the origin of that tumor. And this is just putting them all together next to each other, and then you can tell all those black, dark areas where the tumors are, and then they're still showing there. This is after that first treatment. You would notice that how that side is becoming cold or dark, and then now on this side. And then you can look at the way the liver looked on the right, and then how it looked before on the left. And this is that image as the patient is looking at us, and with the arms raised. And again, you see how it's black, and then suddenly it's so lighter there. Those two guys are the kidneys. This is the bladder, and this is the spleen. And this is May 2021. So came in 2016. 2017 had first treatment. 2018 second treatment. This is May 2021. So that's already 4 years, I guess, if I'm doing math correctly. And this is last month. This is last month. The only thing that's still showing up is just a little bit of that, which was the biggest tumor. And for this, I was like, don't do anything right now. I mean, if this grows, if patient have symptoms, then we will intervene. And that should be it. Thank you.